Welcome back to another episode of Alate Health Presents. I'm Dr. Andrew Doe, here with Dr. Michelle Maneevese.
Hi, I'm Dr. Michelle Maneevese, another interventional radiologist here at Alate Health. Welcome.
Dr. Maneevese, I'd like to talk about interventional radiology. We've talked about prostate artery embolization, uterine fibroid embolization, disease within the circulation, veins, and arteries. And I think I want to let the public know and our viewers know what is interventional radiology. Today I had a patient who came to see me and said, I'd never heard of interventional radiology before. And his wife, who was actually a nurse, said, I really didn't know anything about it either. And I think you guys need a better name, which I agree with. But tell me, what do you tell people when they ask you what is an interventional radiologist?
That's a hard question, and I think that's why it's hard for us to describe what we do, because we do so much. Like we said in prior episodes, there's no body part, organ system that interventional radiology cannot help. But one thing that all of our procedures have in common is that they're minimally invasive. And so I think that's kind of what unites what we do.
I agree very much. And one of the things I was thinking about as I was thinking of a new name for us is more of an idea of an image-guided surgeon. And I think what I'd like to convey to patients is we can use some sort of imaging, X-ray, ultrasound, CAT scan, MRI, something that shows us what's going on within the body, and we can effect a therapy or take a tissue sample without making a huge incision, as you said, minimally invasive. Now, why is it interventionalists can seemingly affect every system of the body without being, kind of that jack of all trades and not really good at one thing? How is it we can be so good at doing so many different things?
Well, one thing is we're kind of surgeons of the blood vessels, and the blood vessels feed our entire body. So if there's a blood vessel that goes to this body part, organ, then we can probably help. One of my favorite procedures that we did in residency and fellowship is traumas. I love the outpatient-based system that we have here, where patients get their procedures and they go home the same day. But just the rush and the energy that I got from those traumas was really fun. Sometimes patients would get in a motor vehicle accident or a motorcycle accident, and they were bleeding internally. And if they weren't a surgical candidate, if they needed someone to just find that one bleeding blood vessel and just stop it from bleeding and the patient from losing so much blood, we could save a life. And you were in a time crunch, everything happened so quickly, but that was one of my favorite things to do.
Mine as well. The idea that you can take a healthy young individual, I always think of the motorcycle accidents. I saw a lot of those when I was training. And you go in, and I tell my friends, I do plumbing on people. And if it bleeds too much, I make it stop. If it doesn't bleed enough, I make it bleed. So, but I can remember those incidents where the patients would come in losing a lot of blood. They were young and healthy, 20, 25-year-old people. And not only was it a time crunch and where you're working against a very serious issue, but the patients would turn around, literally right there on the table. I would see the blood pressure go up, and you would know, hey, I've saved this life. And I think to be able to do that through a tiny little needle is really amazing. Now, what would you say is kind of your favorite technique or part, of what we do in interventional radiology?
One of my favorite things about interventional radiology, and kind of what drew me to the field, is that as soon as the patient leaves our suite, we've made a difference. And I am all about getting that, quick return, seeing results immediately. So, if someone has fibroids, we've embolized them. They're on their way to dying. Someone has a big prostate causing lots of trouble, we're shrinking it, and they're going to feel better. In terms of biopsies, interventional radiologists also perform biopsies. As soon as that patient leaves the suite, we have an answer for them to help them guide their therapy. And in addition to therapy, if our patients are getting chemo, and they need access, we also do that too. So the minute they leave, they have an access that they can use to help in their treatment. So all of these things really drew me to the field, making a difference quickly, and doing it all minimally invasive.
Excellent, excellent. So now, what are some of the procedures that Alate Health is looking into in the future? I know you said things about like chemotherapy. How about the idea of treating patients that have tumors in their liver?
So treating tumors in the liver, most of the time you can use chemo, right? But as we all know with chemotherapy, it can also hurt the cells that are healthy as well, and that can make you feel really sick, make your hair fall out, and make you feel terrible. The good thing about these tumors, though, is they require a lot of blood supply, and with that, it's being fed by the blood vessels. That means an interventional radiologist can get to it. So same thing that we would do with a prostate embolization or fibroid embolization. We put a tiny IV into the right groin, put some dye in, use our big x-ray machine to see that dye, and we find that one blood vessel that's feeding that tumor and give chemotherapy into that one blood vessel, and chemo only goes to that tumor.
Excellent. Now, there are also other areas of cancer treatment where interventional radiologists are becoming even more and more involved. Sometimes we won't even put in these beads with chemo on them or with some kind of radioactive substance to kill the tumors. We'll actually just plug up the blood supply and use an outside source. We can use the x-ray machine and the blood vessels to stop the blood flow, and then we can also go directly into the tumor using a CAT scan and destroy the tumor from within as well. Now, what is it about the outpatient setting and interventional radiology that kind of meshes so well? I know we don't do trauma. Obviously, you need to be at a big hospital in the emergency, or I should say the trauma center. But what is it, do you feel that the interventional radiology works so well in this outpatient setting?
I think it goes hand in hand. So we're doing all of our procedures through a tiny pinhole. So when you're done, there's not a huge incision that we have to deal with. There's not a lot of pain control that we would have to admit a patient overnight for. All of these things would, in a hospital setting, you would have to stay there. But with interventional radiology, all through a pinhole, patients, there's really no need for them to stay.
Excellent. And I think that, as the technology gets better and better and we get to be able to do more with even a less of an entry point, as you said, a tiny IV, I think the recovery and the risk of having complications actually goes down as well. Now, something that comes up, we see patients that have seen other interventional radiologists. We've seen patients that have researched their own procedures, especially with the uterine fibroids. Some patients have come to us and said, I went and saw Dr. X, and the thing I really didn't like was the idea of them using the artery in my wrist. Tell us a little bit more why you and why Alate Health prefers to use the arteries in the legs to do the fibroids instead of the wrist.
Sure. So the wrist is just another access point, right? If there's a blood vessel, we can get to it, and all the blood vessels are in kind of a highway that are all connected. So you can get to it through the wrist or through the groin. I think there are some procedures with the angle of how the wrist goes down into the body, it would make the procedure easier, technically easier to perform. The reason why I'm a little more uncomfortable and I prefer to go through the groin is that, through the wrist, there's a small chance that you could lose your hand, that the IV there could be occlusive, and I wouldn't want to take away someone's livelihood or even have a chance of ruining someone's life by them not having a hand anymore. And so with that, I really focused on, and Dr. Doe and I both focus on our technical skills so that you don't lose time, you don't lose accuracy, you don't lose any precision with us going through the groin. Now the groin, the femoral artery is huge. It's, it's so easy to get into. And even though the angle is a little more difficult, if you just come visit us in one of our suites, you won't know the difference between Dr. Doe and I and someone else going in through the wrist.
Yes. And especially with fibroid patients, these are young, healthy women that are still having menses, which is very important as far as your arterial health goes. Women have that estrogen that protects them. So going in through the femoral artery is extremely safe. Now, one of the complications we see with any kind of arterial puncture is a small amount of bruising or some blood leaking out of the artery. If that leaks out in the forearm, as Dr. Maneevese said, there's a risk of losing a finger or a hand, things like that. Also, these catheters travel so far, they can get close to the blood vessels that are going to your brain. You have risk of other issues with that, whether they be stroke or things like that. Mm-hmm. And for me, I think the idea of using the wrist is kind of something that's just in vogue. Mm-hmm. And like you said, it's technically easier. It's kind of a hot topic right now. The idea that the patients can get up and walk around so much faster. Now, how long are our patients down at Alate Health?
So after the procedure, if we did a prostate embolization or a uterine fibroid embolization, they're laying down for 20 minutes. And that is, from the very end of the procedure, 20 minutes after that, and then we get them up and walking. Most of the time at 20 minutes, the patients are still sleepy and they kind of, just want to hang out with us for a little longer. So they're really not, gung-ho about getting out there and finishing about and going about their day. So really the 20 minutes fly by.
All right, we're going to take a short break, but please stay tuned as we talk more about interventional radiology, and we'll even get into the global reach of what we do and how we can affect patients all over the world.
We'll be right back.
During the Cadillac Season's Best Sales event, Ron Carter Cadillac, Houston's only Cadillac to-your-door dealer, delivers 0% APR for 72 months, plus $3,000 bonus cash on both the first-ever 2020 CT4 Luxury Collection for only $449 a month, and the first-ever 2020 CT5 Luxury Collection for just $499 a month, both with only $1 down. Gulf Freeway, just 2 minutes south of the Beltway.
Shop smarter when you shop Ron Carter. Ron Carter, Cadillac.com.
Have you been injured in an 18-wheeler accident, truck accident, car accident? Was someone texting and ran into the back of you, not paying attention? It doesn't matter what it is. Give me a call, Attorney Willie Powles. We'll fix it today. The number is 281-881-2457. Again, that number is 281-881-2457. We'll fix it today. Call Attorney Willie Powles.
During the season's best sales event, Ron Carter Cadillac delivers 0% APR for 72 months, plus $2,500 bonus cash on all 2020 XT4, XT5, and XT6. Or drive 2020 XT4 Luxury Collection, only $299 a month. 2020 XT5 Premium Luxury Collection, just $369 a month. And first ever 2020 XT6 Premium Luxury Collection, just $399 a month. All for 39-month lease with just $1 down.
Ron Carter, Cadillac.com.
I'm Attorney Willie Powles. Allow me to express myself with you. If you've been hurt or injured in a car or truck accident, give me a call and we'll get it fixed today.
We are back. Thank you for joining us again on Alate Health Presents. So for this segment, I want to get a little personal. I want to know more about Dr. Doe and his training and what led him to interventional radiology. So Dr. Doe, where did you start off? Where did you go to medical school?
So I started medical school in Syracuse, New York, part of the state University of New York system called Upstate Medical University. Now they've changed their name. And I went into medicine, big picture. I went in because I enjoyed helping people. I had, kind of volunteered at the hospital. I had worked as an EMT, and, I really enjoyed it when patients got better. or when, you know, you could really affect somebody's life. So after that, I went to a smaller city south of Syracuse for my internship and went back to Syracuse for my residency training in diagnostic radiology. And then I finished in Albany, New York, was where I did my fellowship in vascular and interventional radiology.
And what was is there a main focus that Albany had procedure-wise?
So at Albany, I had four mentors, and each one of them was they were all equally capable, but each one would have their little area they had expertise in. And one of the most influential people in my life, be it in life or be it in medicine, was Dr. Gary Siskin, who is very adept and one of the leading experts on fibroid embolization.
So that explains it. That's where the bug bit you, and that's where it started.
Absolutely. You know, I first looked at interventional radiology way back as a medical student, and I enjoyed it because it was surgical. It was kind of, as you said, fast results, and you really were helping people. And the other thing that was very attractive about it was a lot of times we were kind of the last line. You know, the patient had gone through surgery and had some complication, and now they were looking, the surgeons, the doctors were looking to us to really be the defining thing that could get them better. And a lot of times, you know, we had to be there. There was really nothing after what we had to offer for these patients. So that was kind of exciting as well, being the doctor's doctor.
The doctor's doctor. So we were talking about how our name can be misleading and not a lot of people know what interventional radiology is. We could be the doctor's doctor or the superhero doctors, the last line of the very end.
I don't think I go that far.
So when you were going through your studies at Syracuse and then at Albany, were there similar techniques, or do you feel like you learned a different subset at each institution?
I think I saw a lot of different approaches to the same, not only the same disease state, but the same treatment, even though, you know, everyone does a uterine fibroid embolization. But the techniques, how you start, how you finish, what you're looking at, your thought process, you know, was very different amongst the different individuals. So I think one of the things that really stuck with me was, you know, this is a specialty, but there's not a really set rote way to do things, and it's a constantly evolving specialty because it's so technology dependent, and because a lot of our procedures are the newest procedures, and we're always kind of on the cutting edge of medicine. There's not really one specific way you have to do things, and you know, the human body is not the same from person to person. So the ability to adapt and to use different techniques that you've learned over the years from different mentors, I think was really what I saw being in different places within the state of New York and in different areas of watching different people do the same treatments.
And seeing you in action, that's very obvious. You know, he'll just look at the screen and say, oh, I've seen that turn before, get me this catheter. Or it's just so quick how Dr. Doe can just, you know, make a decision and then that thing just works because he's seen it so many times. And the way he practices, he pulls from every single area that he's been in. And our patients greatly benefit from that.
Thank you. So, Dr. Maneevese, how about your training? And you know, we know you're a Texas girl, lucky you, born and raised. But why did you go where you went? What brought you to medicine? What brought you to interventional radiology? And what are your key things for interventional radiologists?
So I am a Texas girl through and through. I didn't think anything could take me away from Texas. So I did medical school at UT Houston, did my internship at UT Houston MD Anderson, and did my radiology fellowship at UT Houston MD Anderson. And when it came time for fellowship and deciding where I wanted to go, I kind of felt like I already know the Texas way to do interventional radiology. You know, I could predict which one of my attendings would get out of trouble this way and this way. And I felt like I already had a really good, backup plan the Texas way. And so I just wanted to go somewhere else and see how interventional radiology is done elsewhere. And so I applied to Yale because one of the main reasons is they are one of the busiest prostate centers in the U.S. And Dr. Raj Ayagari is just the prostate guru up there. And so I figured, the prostate is the most technically difficult procedure that we offer. I want to learn that, and I want to learn it really, really well. So that's how I ended up at Yale.
Excellent. So as far as the prostate artery embolization goes, who is doing them in Texas? Or I should say in Houston, I guess. We'll start there.
Well, in Houston, that's a good question. You. You do them.
Yeah, we do.
Me.
I do, yeah.
I do them.
That would be we.
And between us, I would say, there's no one else in Houston that is as experienced, has seen as many cases, has seen complications done by our colleagues, and knows how to get around those complications. Dr. Doe and I will assist each other during prostate artery embolizations, and as soon as we see something that could be a red flag, that could be trouble, we both instantly recognize that, and we know how to get around it. So that's kind of the plus you get when you get to Alate Health, because really in Houston, it's just us.
Yes. And what is it about interventional radiology in the outpatient setting? My take on setting up Alate Health was to really make our specialty real doctors. And, do you see yourself kind of in that mold?
I do now. So, I think where you train, there's different mindsets. Up at Yale, we were very patient-centered. We saw the patient initially in clinic. We did their procedures. We did their follow-ups. We managed all of their complications. I think in Houston, interventional radiology isn't really seen as that yet. But now that I'm here at Alate Health, I get to be the physician that I want to be, all around, well-rounded physician that works on a team to take care of our patients. Yes,
and as Dr. Maneevese spoke of earlier before the break, interventional radiology can affect, any organ system in the body. So, the idea that you have to be a real doctor really rings true with interventional radiology. Now, Dr. Maneevese, I started Alate Health. Dr. Maneevese has, really done amazing things within the world, not the world of interventional radiology, but within the world. Can you tell us a little bit about your passion and about how you're changing the world through interventional radiology?
That's an exaggeration, but at Yale, we started a program where we're bringing interventional radiology to Tanzania. I truly believe with all of my heart that minimally invasive and good quality healthcare should not be a luxury. And so every month for 2 weeks, we send a team of interventional radiology. So we have an interventional radiologist, a fellow, a resident, a med student, a nurse, and a tech, so an entire team that goes out to Maneevese Hospital, and we train them to do exactly what we do over in the U.S. And I think a lot of times with the mission trips, it's hard because when you go out there, you do the work and then you leave, and that's the problem. You leave and everything goes with you. But with us, we go there, we teach them our skills, and when we leave, those skills stay right there. And so they get to continue serving their patients in a minimally invasive manner. And we actually started with the uterine fibroid embolization. So a lot of the women were getting hysterectomies because that's their only option. They still wanted to have children, and the mortality rates were really high because of infection. So they asked us, do you think it would be possible? It's always possible with interventional radiology. So we performed the first ever uterine fibroid embolization at Maneevese Hospital.
Wow, that's amazing.
And from that, it has just grown and grown.
Excellent. So do you plan on continuing this while you're here at Alate Health?
Absolutely. Absolutely. And as soon as it's safe to travel again, you and I are going to be the next ones up.
So as we close out the show, you can always, if you want more information, you can always visit our website at alatehealth.com. If you want to donate for the Tanzania Mission Project, is there any way that any of our viewers could do that?
Absolutely. So it's on the Yale Interventional Radiology website. You can also search Road to IR and give in that way.
And Dr. Maneevese is very popular on Instagram. You can find her at I don't want to spell it, Maneevese. Or myself at Andrew Aldo MD. And again, alatehealth.com, 713-955-1707. And let's touch on it again, Dr. Maneevese. Our second center, Alate Health Southeast, is now open. We did our first day there today, and we look forward to bringing our skills to the Southeast. And that location is 12825 Gulf Freeway. And that's the location, but you can call our main number and schedule at any of our locations through that. So take care. We will see you guys in the new year. And we wish you all a very Merry Christmas, a Happy New Year from myself and Dr. Maneevese.
Until next time.